So good morning, good evening, and good afternoon, everyone. My name is Adiba Kamarul-Zaman. I'm the president of the International AIDS Society, and I'm from the University of Malaya in Kuala Lumpur, Malaysia. I'm very pleased to welcome all of you to this official media roundtable ahead of the IAS COVID-19 conference prevention. Today's discussion will be less formal than a press conference. The COVID-19 science is, as you all know, is an emerging field with rapid changes every day. And our goal today with this roundtable is to have a discussion among scientists and to answer your questions about the latest evidence and what's next in the global response to COVID-19. Tomorrow, we will join conference co-chairs at the closing session entitled, What's Next for the COVID-19 Response. If you have a question, you may submit them at any time by typing them into the Q&A feature at the bottom of your screens. Please either type your question in full or type the word question, and we will unmute you to pose the question directly. In both cases, please be sure to state your name and outlet. And please note that some members of the media are recording this conversation to broadcast all or part of it. Now it's my great pleasure to be joined today by two esteemed colleagues and friends who don't need much introduction. However, Dr. Linda Gail Becker is a past IAS president and is a co-chair of the IAS COVID-19 conference prevention. She's currently the director of the Desmond Tutu HIV Center at the University of Cape Town and also the principal investigator of UCT's clinical trials unit and the chief operating officer of the Desmond Tutu HIV Foundation. Our next speaker, of course, needs no introduction. Dr. Tony Fauci, who's made time to be with us this morning, is director of the National Institute of Allergy and Infectious Diseases at the US National Institutes of Health. And he has served as a key advisor to 6 US presidents and their administrations, including the current one. Welcome, Linda Gail and Tony. To begin with, I would like you to both share some opening thoughts on where we are in the global response. And perhaps, Linda Gail, we can start with you.
Thanks, Adiba, and thanks to, of course, to Dr. Fauci for joining us at this meeting. We're looking forward to it tomorrow. I think really fantastic state-of-the-art talks and a lot of abstracts also for us to learn the latest in terms of science. I'm not going to take a lot of time because we don't have a lot of time this afternoon. I know you all want to hear from Dr. Fauci, but I reflected for a moment, and I must say, somewhat inspired by the wonderful talk that Dr. Fauci gave at the R4P conference last week in the opening plenary. But as I reflected, being a South African and dealing with the fact that we have had 43,000 known COVID deaths in this country and probably about 120,000 excess deaths due to natural causes since the start of the pandemic. So looking really more like 150,000 deaths in this country, I have come away with the real notion that we should never underestimate the pathogen. That's perhaps the axiom that I want to underline as we move forward. As everyone knows, there has been a lot of talk recently about new mutations, new variants, and that is certainly what circulates in my mind at the moment and really raises the question of how soon and how wide we can go with vaccination. This is particularly because I was very involved in the Johnson & Johnson Ensemble phase 3 trial, which of course just read out on Friday. This morning, I was at a site talking to elderly members of communities where non-pharmaceutical interventions such as social distancing is almost impossible to do. And these elderly folk were so happy to have been part of a clinical trial where they believe they may well have received a vaccination that has saved them the pain and possibly the terror of going down with SARS-CoV-2. So those are my top of mind thoughts at the moment. And with that, I'll hand back to you, Adiba.
Thank you, Linda Gail. Tony, can you share with us your thoughts, please?
Yeah, thank you, Adiba. I just want to underscore what Linda Gail had said about this extraordinary pathogen, the likes of which we really have not experienced in over 102 years. When you want to talk about the metaphorical aspect of saying that a microbe is a cunning enemy, this is a most extraordinary cunning enemy that has so many characteristics that have foiled us along the way. A microbe that has a spectacular capability of spreading from person to person, that does something unusual that I've never seen before with a viral pathogen, where more than half of the people who get infected from someone who has no symptoms. About 40% of the people who are infected have no symptoms. So you would think, well, that's pretty mild. I mean, a lot of people don't have symptoms, so this is something you don't have anything to worry about. But again, if you want to give that metaphorical attribute to this virus, it then seeks out vulnerables. And the vulnerables are the people, the elderly, and those with underlying conditions. It seeks out people who are in so many respects throughout their lives in compromised positions. In the United States, the disparity between minorities and people who are economically less fortunate, an overwhelmingly greater disparity towards them. We in the United States, as a rich country, have proven that being rich and having a lot of resources doesn't protect you from something as extraordinary as this virus. As you know, we've gotten hit worse than anybody in the world. We have now about 430,000 deaths. And there was a point when we were having up to 400,000 new infections a day and over 4,000 deaths per day. It's tough to get your arms around that, to think about that, but that's what's actually going on. I hope, and I know we'll get into the question period about the fact that science has really come through for us. Many public health measures that Linda Gale mentioned, that it is sometimes very difficult to implement non-pharmacological ways of public health implementation. But the fact is, if you look at science, particularly in the arena of vaccines, where we have multiple different platforms, 3 separate platforms, all 3 of which now have shown that they're capable of inducing a response that in variable ways will be protective. We have the mRNA, we have the various viral vectors, and we have soluble proteins. And I think what people need to appreciate, that even though you may not have, as Linda Gale mentioned, she was very much involved in the J&J, people look at 72% and they say, well, that's not as good as 90%. But the fact is, if you look at serious disease, it was extremely effective in preventing serious disease, including hospitalizations and death. So we're in an unprecedented challenge, but there is light at the end of the tunnel if we can implement a global program to get the world vaccinated, not just the rich countries, but the entire world. So I'll stop there and I'm happy to answer questions.
Thank you very much, Tony. On that note, I want to get your thoughts on how we can ensure that there's equity in the global vaccination program, because at the moment, I was just asking Linda Gale, when will South Africa receive their vaccination? And she threw up her arms in despair. Here in Malaysia, we will probably get the first 1 million dose for frontliners in late February, early March. So what can be done to ensure better global equity? And of course, WHO put out a call to the UK to put a pause to their vaccination program to allow more countries to access the vaccine.
Adiba, I think there needs to be absolutely major investments of resources to get plants built that can use vaccines that have already been developed to really get the planet vaccinated. And that really requires a different paradigm. It requires an enormous amount of resources that have to be given. One, because I believe, as with the spirit of PEPFAR, that the rich countries have a humanitarian obligation to do that. It's almost a moral equivalent of things that you have to do. And then once you do that, there's also enlightened self-interest, because we know from the variants that have been emerging that if you just so-called protect your own country without protecting the world, this will go on and on and on. So it's in everybody's interest, ranging from a pure humanitarian to a solidarity area to the fact that is for your own self-interest. So we really, and Linda Gale over the weekend and I have been communicating about what can we be done. And by the way, we're making progress, Linda Gale.
Thank you for that. So I'm going to ask you a few questions that the media have posted here. Now, on that similar vein, a question from Bu Su Lin from Malaysia: should the EU cancel vaccine export controls since they will affect other countries in Southeast Asia, including Malaysia, among others? Did you get that question? Should the EU cancel vaccine export
Are you asking me?
Yeah, sorry,
I'm
Tony.
sorry.
Yeah.
I thought, I'm sorry. Please repeat the question. I didn't realize you were asking me.
Sorry, should the EU cancel vaccine export controls since they will affect countries in Southeast Asia, amongst others?
You know, Adiba, I can't answer that question. If I do, it becomes a global soundbite, and I really don't want to do that. So,
okay.
Yeah.
That was from the media. Yeah. All right.
Yeah.
Okay. A question to you, Linda Gale, from Ashley Furlong at Politico Europe. Several of the vaccines seem to be less effective against the new variant first detected in South Africa. How concerning is this to you and other researchers in South Africa, since the J&J vaccine seems to be even less effective in patients with HIV? And could you explain some of the reasons for this and the possible implications for a country such as South Africa?
So Adiba, I always go back to what data have we got? So we've got data on 2 vaccines that have actually been tested in South Africa against, a circulating new so-called new variant, and that would include J&J and Novavax. Both of those vaccines showed some reduction in efficacy compared with the testing in the US, where presumably, based on the timing, there was not that much of particularly the kinds of variants we're seeing in South Africa. That would lead me to say that probably there has been some hit in terms of efficacy for these particular vaccines. People need to recognize none of the other vaccines. We may be getting AstraZeneca data in a week or so, but none of the mRNA vaccines have not been tested directly against this variant in vivo, in people. So we wait to hear that. What I will say though, is as Tony mentioned, we do know that across the whole board, across the whole world, certainly the J&J vaccine stopped deaths. So that included South Africa, and it stopped severe disease. So that included South Africa. So I'm heartened by that, but I recognize, and I think we all in the scientific world take a little bit of cognizance, certainly, that the variant is having an impact on vaccine efficacy. Now, what I would extrapolate, I'll be interested to hear whether Tony agrees with me, there's a lot of headroom in the mRNA vaccines, and 93% efficacy in the first wave, the first testing would suggest that even if there is a little bit of a ding there, we will still be in a very good space in terms of efficaciousness. And then I want to say, we know that vaccine impact is a mixture of efficacy and coverage. So what I take away from this is if we give up a little bit of our efficacy because we have a mutation to deal with, then we have to be sure to get that coverage out even more. And that, really just spurs us on to the urgency to get the vaccine out there as quickly as possible. Now, the question was raised, is this due to maybe because we have such a high proportion of people living with HIV in this country? On the J&J study, HIV positivity was 2.8% of the whole. So likely not making a huge contribution to that reduction in the J&J. And on the Novavax trial, the numbers were too small. So we will, I think, in time, as the J&J data is looked into, as you know, there were 43,000 people on that trial, a lot of space to really do in-depth analyses. We may be getting more detailed about the folk living with HIV. At this moment, the recommendation remains that HIV positive people should be vaccinated if they can, and we don't have any evidence at the moment to suggest that they have less of a response to the current vaccines. Thanks.
Thank you, Linda Gale. And on the issue of variants, a question from Marilyn Macioni to both of you. What do you think about the variants and the risk of reinfection, and how concerned are you about that risk?
Well, I believe, and Linda Gale can address this firsthand, is that it's very clear that in our communications with our South African colleagues, that they first noticed something was really, really wrong when they were getting individuals who clearly had documented infection with wild type who were getting reinfected, which tells us that if you look at the results of the trial and mine into the data, that previous infection had very little efficacy in preventing reinfection. So if you hold on to that for a second, yet, as Linda Gale has said, vaccine with even a less than perfect vaccine against the variant did give some degree of protection. Not 100%, but as she said, and I like the way she said, the difference between efficacy and effectiveness. If you have a certain degree of efficacy that's low, you can make it more effective by vaccinating more people. So it appears, and again, we haven't directly demonstrated this, but my looking at the data suggests, and I want to underline suggests so that people don't say I've made a definitive statement. It looks like the protection induced by a vaccine might even be a little bit better than prior infection. And I'm wondering if Linda Gale would agree with that, because prior infection seemed to have very little protection against reinfection with the variant, whereas vaccination, although it wasn't perfect, it did pretty well. Linda Gale, do you think I'm going down the right track on that?
Yeah, Tony, I agree with you, and I see your hesitation because usually, you know, the sort of best thinking around this is a wild type is always better than a vaccination. So again, this is kind of not sticking to the storyboard. But, you know, when you drill down on the data we saw from Shabir Mahdi, Dr. Mahdi the other night on the Novavax trial, small amount of South Africans involved in that, 4,500 people. But what he noticed when he ran, I'm going to quickly go through it because I think it's an important observation. He had a 30% seroprevalence at the time when people enrolled in that Novavax trial. Of the people who were in the placebo arm, there was a similar rate of COVID infection in those people who were seroprevalent at the beginning of the trial. In other words, they'd been exposed, to those who had not been exposed, suggesting that there was no benefit of previous exposure. Now, remember, previous exposure would have been variant old, initial variant, wave 1. Whether being infected with wave 2 will protect you against the current circulation, I'm hoping that, because I'm one of those people. So I'm a survivor of wave 2, and I'm hoping, you know, like Bellico, that's going to hold me for some time. But, you know, I think at this moment, all we can do is continue to gather this data and keep an eye on it. But again, the message has to be, let's vaccinate while we've got a window of opportunity and a set of vaccines that work against the current rotating virus.
Yeah, so Linda Gale, on that note, there's a question from Heather Bonner from Medscape. Do you see a role for testing for the antibodies before during the vaccine rollout?
I don't think we can. You know, and again, we've been watching countries to the north of us. I mean, I think it's just amazing when I see that the United States of America is doing, you know, well over 1 million vaccinations a day. On Sunday, I think 1.4 5 million yesterday. I know that's still a little way off what is Tony and the folk there's goal, but it sounds extraordinary to be reaching those numbers of people on a daily basis. I think you don't want to put any kind of barriers to getting a vaccine out. I think the minute you throw up any kind of stranglehold, you're going to slow things down extraordinarily. So I would not advise that personally, and I'd love to hear what Tony has to say about that. I do think, though, that getting antibodies out for other reasons, antigen tests out for other reasons would be very valuable. I'm trying to decide at the moment, who can go back to work amongst our healthcare professionals, etc. And I've been sad that there's been such a slow rollout of rapid antigen tests for that reason, but I would not put it as a barrier to vaccination.
I totally agree. There are no barriers in the United States. We don't test for antibody. We don't test for virus. We just vaccinate people who want to get vaccinated. If there's another reason to test for antibody or for virus, we go ahead and do it. But if somebody walks into a clinic or some of our healthcare providers or people in the community want to get vaccinated, we just vaccinate them.
Okay, more questions on vaccines in the controversy. This one is about the UK's decision to delay second doses of the Pfizer vaccine in order to make them cover more people in the initial rollout. I think there are a couple of questions around that.
So I'd love to reframe that for Tony, if I may, Adiba. I saw Monica, Dr. Gandhi's thread yesterday where she was saying, are we as academics a little too stuck on protocols? So we want to follow the protocol that was tested in the phase 3. Is there a pragmatic viewpoint where you go out and you get as many vaccines into arms as possible, and there's a little bit of leeway about when you follow up, etc.? And I thought that was extraordinarily provocative, and I wondered what you would say to that in terms of pragmatism versus protocol.
Well, Linda Gale, as you well know, let me state it so people don't get it wrong, but I know where you're going, and I'm going to agree with you in a second, is that clearly the data, the science tells us that with Moderna, it's 28 days. With Pfizer, it's 21 days. What we were saying, and the CDC actually has this in their guidelines, is that if you can stick to that, that's optimal. But if someone, for one reason or other, is a bit late by a couple of weeks, it's better to do it then than to say, oops, you're off schedule, so we're not going to give you the second dose. You need the second dose. There is some wiggle room. That doesn't mean people should not go for 21 and 28 days. But if you can't do it, it's not the end of the world if you delay it a little bit. If you want to delay it by 6 months, that's different. I mean, because there's no data on what that means. But the difference between 4 weeks and 5 and 6 weeks is not that great, even though you should try your best to do it on time.
Okay. I guess the related question was about vaccine rationing and giving to more people versus ensuring that fewer people get 2 doses. That was your question too, wasn't it, Linda Gale?
Yeah, I mean,
no, go ahead.
So yes, no, I was just going to say, I think again, it always comes back, and you're talking to folk who, Tony's been doing this for longer than I have, but clinical trials are my life. Clinical trials tell us how we need to use products. That's all the data we have. Sometimes we're pushed to ration or extrapolate, but I think we need to know we're in a data-free zone when we do that. Tony, I'll hand it.
Yeah, so Adiba, let me just articulate what is discussed a lot in the United States and sometimes gets confused. And that is that when you have rollout of doses coming from the factory where it's made, into the fill and finish, into the trucks and the planes, into the clinics, wherever they may be, locally in the United States, what we started off with was that we wanted to make sure that you would guarantee that a person would get their second dose on time. So when a certain amount of doses were produced, let's say you wanted to vaccinate 50 million people. That ultimately would mean you need 100 million doses for a prime boost. So early on, when things first started at the end of December, if you had 100 million doses, you would give out to 50 million people and you would hold back 50 million to guarantee you'd get the second dose. And what we found out is that once you get confidence that you would roll things out, instead of holding anything back, as soon as you get a dose, give it to people as their first dose. As the next shipment comes in, when the people are ready for their second dose, they get the first priority to make sure everybody gets a second dose. And then what's left over, then you give others their first dose, which means you're never holding things back. Better it in somebody's arm than in a freezer or in a refrigerator. So long as you have confidence that the flow and the cadence of doses will not have people who get their first dose miss their second dose, because you don't want them to miss the second dose. That's what the confusion is sometimes when people talk about holding back versus giving everyone a first dose.
Mm-hmm. Okay. All right. Now, perhaps we can move away from vaccine to a question on long COVID from Terry Wilder at the Body Pro. The recent body politics study that Francis Collins highlighted in his blog shows that 4 of the top 5 long COVID symptoms are the same as the IOM diagnostic criteria for myalgic and for chronic fatigue syndrome. In what way can the NIH integrate chronic fatigue syndrome research into the new 1.15 billion long COVID program so that we don't experience a second pandemic of ME, chronic fatigue syndrome? Tony?
Yeah, Adiba, we're still trying to get our arms around this whole concept of, well, it's referred to as long COVID. We've given it a different name, a post-acute COVID syndrome, or PACS, P-A-C-S, because it's kind of, I don't think a good name, say long COVID. I don't know what that means, but for post-acute COVID syndrome, there are things. First of all, we had a workshop on December 3rd and 4th, bringing in people from, from all over various disciplines to try and put together a research agenda, which we will be putting a considerable amount of resources into trying to find out through cohorts what the extent of this is, what percentage of people get it, namely people who are only hospitalized. Doesn't seem to be the case. There are some people who just get COVID, get a mild to moderate disease that doesn't even require hospitalization. Yet what we're finding is that there's a certain percentage of people, and we don't know what that percentage is yet. We need to do cohort studies, who have varying degrees of duration, anywhere up to several months or more, where they have a constellation of syndromes, some of which, as Terry mentioned in her question, quite similar to what has been referred to as myalgic encephalitis chronic fatigue syndrome. And it is, rather consistent. Profound fatigue, muscle aches, temperature dysregulation like dysautonomia, sleeplessness, and then something that people refer to as brain fog, which is sort of a strange word to say you really can't focus or concentrate. That needs to be separated from people who've been in an ICU, been on a ventilator for 3 weeks, have pulmonary function abnormalities that are not getting back to normal, have cardiac output that's down because of cardiomyopathy. Those people are going to have chronic symptoms until they either recover or not. That's a bit different from people who seem to have cleared the virus, but they just don't feel the same for weeks and weeks and months. That's what we're trying to find out. A, what it is, what's the pathogenesis, and is there any treatment?
Thank you for that. I'm afraid we can't get away from vaccine questions. There are lots of on it. So this is from Maureen McKenna from Wired US. As you look forward, do you anticipate that this virus will become endemic, and what would that mean in terms of regular boosters or developing a childhood vaccination program? Linda Gale or Tony?
Go ahead, Linda Gale.
Yeah, I mean, I think that to a certain extent is going to depend a little bit on our vaccination program, right? So initially, if we can get vaccines across the world, I mean, what have we done with polio? Polio, finally, we've managed to get rid of, but that took a really amazing global campaign to get vaccines to everyone. I think if there are parts of, as we've already said, if there are parts of the world where we don't, or we do it with a kind of leaky penetration, then the virus will grumble on, it will continue to mutate, and we will need to run after it. And that's the bottom line. I think that, it's a virus. That's what viruses do.
Totally agree. And it gets back to the question that you asked, Linda Gale and I. If we don't get a global effort, without a doubt, this is not going to go away, and we're going to continue to have it come back with different forms of mutant, which is another really good reason to have a very, very intensive global effort to do with COVID what we did with smallpox, with polio, with measles. You got to get the whole world vaccinated.
Yeah, totally agree with that. On a related question from Shobha Shukla from Citizen News Service India, some countries have approved vaccines for which there is no data for phase 3 efficacy studies or no published data, full stop. Is this ethical? And this is only going to increase vaccine distrust. Should not the WHO issue an advisory against use of these vaccines to the public?
Well, I mean, you probably get the same answer from Linda Gale and I, because we are scientists and clinical trialists, and we feel strongly that decisions, particularly that have a major public health impact, should be made on the basis of scientific data and evidence. And it really can be not only dangerous, but it can decrease the credibility of the entire process if you approve an intervention without any data for it. So that's something, I'm not sure what the exact regulation against that, be it WHO or whatever, but that's something that we strongly discourage.
Yeah, and I think the point being that we want to do everything to actually enhance trust in vaccination at the moment. I would hope that countries who presumably have regulatory authorities would also be upholding that concept. So yeah, couldn't agree more. Adiba, you're muted.
Yeah, sorry. So here's a practical question that I myself have been asked a lot. The WHO doesn't recommend the COVID-19 vaccine to pregnant women unless they're at higher risk of infection. CDC recommends that it's up to the mothers after having a conversation with their clinician. Why the difference in recommendations between the two agencies?
Well, there was a stronger difference that was corrected, because a little while ago, must have been last week, the WHO said it's a contraindication. You shouldn't vaccinate pregnant women. And the CDC, our CDC, had said that it really is a choice of women. And we found out, by the way, that in the clinical trials, it was an exclusion criteria. But once we got an EUA, an emergency use authorization, within a very short period of time, there were 10,000 women who were pregnant who got vaccinated. Many of them, as Linda Gale knows, were healthcare providers who were taking care of COVID patients, saying, I'm pregnant. To me, the risk benefit is I want to protect myself against COVID. So we had a lot of pregnant women vaccinated. The FDA followed them and continue going to be following them. And so far, no red flags. So the CDC sticks by its recommendations, saying it's up to the woman. It's a risk-benefit ratio, even though we don't have good data on it. The data that we're collecting so far is no red flag. So if a woman who's pregnant wants to get vaccinated, that's fine. When that happened, WHO pulled back and said, okay, it's not a contraindication. If you're in a high-risk situation, I guess like South Africa, then you should probably get vaccinated. So I think they're coming closer to closer in their recommendations.
Anything to add there, Linda?
Yes, that I couldn't agree more. And if I was a woman in that position, I would expect to be consulted and to have that risk-benefit ratio kind of discussion. And, you know, we've been down this road with dolutegravir, we've been down this road with other agents until we get to the point where we can, you know, as quickly as possible involve women of reproductive potential and lactating women in our clinical trials. This is the approach we're going to have to take. It's going to be that risk-benefit discussion, and you know, I think we as practitioners, we or those people distributing the vaccine have to be able to do that.
Okay. A question for you, Dr. Fauci, from Tamar Khan from Business Day, South Africa. What lessons can be learned from the US vaccine rollout for developing countries like South Africa, which are poised to follow suit? And in particular, what can be done to tackle vaccine hesitancy?
Well, you know, it's a question that's pretty broad, because you say from the vaccine rollout, there's so many aspects of the vaccine rollout. You know, there's the shipping, there's the distribution, there's the getting it into people's arms. I think one of the lessons that we've learned is that you've really got to have a pretty well-organized, on-the-ground, local capability of getting it into people's arms, because in the beginning, we had vaccines that were delivered and it wasn't an efficient process in getting into people's arms. And there was a discrepancy between the amount of vaccine that was delivered and the amount that was in people's arms in some areas. What we're facing now is overwhelmingly that the demand is greater than the supply. So we went from inefficiently getting it into people's arms to quickly having a situation right now. We have an enormous demand and the supply has not yet met it. So that's the reason why President Biden has done whatever he can with executive orders to expedite getting these doses to the people who need them and getting it as quickly as possible. It's a very complicated issue. I mean, the idea of the balance between supply and demand, particularly early on when you're starting to get doses, you have to have prioritizations, which we did do. You know, the first people who get it were healthcare providers and people who were, I mean, healthcare providers particularly, I think, are the ones that you really want to do it, as well as people in nursing homes and extended care facilities, because that's where a disproportionate number of people in the United States are getting seriously ill and dying.
Adiba, this is why, you know, my own heart has been very much in the ensemble sort of space, just because obviously that single dose and not having to refrigerate down to -70 is going to be huge on this continent. And whilst I certainly would not say no thank you to any of the others that, you know, need 2 doses or more refrigeration, obviously it gets easier if the logistics are easier.
And to the question on vaccine hesitancy, Linda Gale, is South Africa taking any steps to educate?
Yeah, so Adiba, we are. You know, I come from the HIV and TB vaccine space, and I always say that our communities actually are in a good environment where there is quite a lot of trust in vaccines. People go to get their childhood vaccines, but I have been struck by the impact of social media and sort of misinformation out there. So my response to this is, what I'm putting out there in the public space, certainly telling my staff, is don't waste your time on anti-vaxxers. You know, denialists, we've been there. They are hard work and they don't necessarily change their minds. But there's a huge proportion, the majority, who are just fearful. They are misinformed or uninformed. They're anxious. They need good information. And the way to deal with that is sympathetic, empathetic, a good information that's given patiently, respectfully, and with good understanding. And often peers are the best people to do that. So equipping up, you know, communities to get out there and really get good information to people is critical. So that's the campaign. I'm hoping South Africa is really going to use this interim while we're waiting for vaccine doses to make sure we're getting that good information out to people.
I couldn't agree more with Linda Gale. We have a situation in the United States. I totally agree with it. There are some hardcore anti-vaxxers that no matter what you say is not going to change their mind. But we have a lot of people in this country, mostly in our brown and black population. And they have a good reason historically to be concerned. We have had some incidents back, the infamous Tuskegee experiments that were done on African Americans decades and decades ago. We have to respect their hesitancy and respect their skepticism and not accuse them of why are you being skeptical. You know, historically for them, they have a reason to be skeptical. You got to get past that by admitting that they have a reason for that, by showing them that the safeguards that have been put in place since then would make that kind of unethical behavior completely impossible right now with data and safety monitoring boards, with institutional review boards. It would be impossible. So once they understand that, then you could explain to them the other reasons they're concerned. Did you go too quickly? And then you explain, well, you know, it's wonderful that we have a vaccine 11 months after we've identified the virus, but that's due to scientific advances. That's not due to cutting corners or carelessness. It's amazing that when you explain that, as Linda Gale was saying, in a very open way, in a way that is understanding of their concerns, you can win over a lot of people.
Yeah. So thank you. And I'm conscious that you need to leave in 3 minutes, Tony. One last question for you. You have spoken quite candidly in recent days about how political concerns have often complicated the response to COVID-19. What can be done to help depoliticize public health, not just in the US, but globally?
Well, that is not easy, Adiba, because, we are living in the United States, as you probably know, just reading the news and watching on television, in a very divisive society. And I think one of the things that we've proven is that you've got to separate public health measures from political ideology. You can't have arguments where wearing a mask or not wearing a mask becomes a political statement. It is a public health issue, period. And there's no doubt about that. It doesn't matter whether you're in the United States, in South Africa, in the European Union, or in Asia. It doesn't make any difference. Public health doesn't know political ideology. And when you're in a public health crisis, you've got to pull together, everybody rowing in the same direction. Otherwise, you're not going to stop what is now, as we all know, this historically destructive pandemic that we're dealing with.
Linda Gale, do you have anything to add to that? Thank you, Tony.
Yeah, again, coming from our HIV experience, we've seen this with harm reduction. We've seen this, I'm delighted that the global gag rule, these things that are so important for public health, for people's lives and well-being, have to transcend our ideology. And too often, our innovation is not impactful because ideology causes its lack of progress. And I think as people in these epidemics, this has been some of our biggest battles, is to ensure that innovation makes the impact it needs to make purely for the good, the global good, rather than because it doesn't favor somebody's ideology. So important.
Do you have more time, Tony? I have one other question.
Yeah, I do have time for one more question.
Okay, all right. This is a question from Malaysia again, from Bu Sulin at Code Blue, Malaysia. How should countries manage COVID-19 epidemics without lurching from lockdown to lockdown?
Yeah, that's a great question, because we had that continual argument. You don't need to lock down completely if everyone adheres to some fundamental public health practices. And there were 4 or 5 of them that we spoke of in the United States. One is uniform wearing of masks, everybody. Number 2 is physical distancing. Number 3 is avoiding congregate settings, including and particularly indoors where you should be wearing a mask. The other one is doing things, weather permitted, much more outdoors versus indoors. And we've seen that now, even in the United States. You see restaurants where there's outdoor dining and it's 25 degrees, but they have these heating lamps over you. It's extraordinary what people are doing. And the other one is washing your hands as often as you can. We found in the United States that states that did that versus states that didn't, the trajectory of cases was without a doubt much, much, much worse in the states that said they didn't want to be involved. So you don't have to lock down completely, because we all know what a terrible impact that has on the economy. You can do something that's a golden mean, where you do good public health measures without having to shut everything down.
Okay. All right. So we've got lots more questions, but I'm conscious that you leave for the White House.
Well, thank you, Adiba. Thank you, Linda Gale. It's great to be with you. Take care.
Thanks.
Thanks.
You.
Take care.
And
You
all the
too.
best.
Look after yourself.
Now, Linda Gale, you'll stay on?
I am, if people are still willing to listen to me.
Okay, of course we're all
I'm
willing
not
to listen to you.
But maybe you can help me answer some of these as well.
Okay, I'll do my best. I think there are quite a few questions that were directed to you. Let me find them. Give me a minute. There were some questions on masks for you, Linda Gale.
Yes.
Yeah. Do you see it?
I did see it earlier, and I think it was around masks being washed.
Yeah.
And I wanted to comment about that. So this is my understanding of masks is if they are not the N95 mask, which is designed to fit perfectly to the face and create a really good closure, and also is of the right sort of fabric and filter to make sure that you don't breathe in or breathe out potential pathogens. So that is the sort of medical grade N95 mask, the kind people would use in laboratories. That is on the one side, and that really is to be advised for people who are going into medical settings and are going to be exposed to the virus. What I think Tony was talking about, and what I think this question was around, was the kind of cloth mask, the homemade or the, everyday thing that people use. Now, my understanding of that is when we breathe out a plume of air. And we now know that SARS-CoV-2 is transmitted as small particles in air. It is airborne. And that plume moves out in front of us. What the mask does is it interrupts that plume so that it actually does, it doesn't mean you don't breathe, but it kind of breaks the plume, and it, to a certain extent, protects you from breathing directly somebody else's plume into your lungs. So we don't entirely know how the masks are working, but it's likely it reduces viral load if indeed you come into contact with somebody who's breathing out SARS-CoV-2. But it's important to know. And so, how many times can you wash it? Should you want, obviously advisable to wash it for hygienic reasons. I don't think that there's a huge limit in how often you wash it, unless it's got a filter in it. And obviously if the filter disintegrates, you might get less of an impact. But I think in terms of these cloth masks, what they really are doing, they don't completely cut your risk. They're not a complete barrier, but they reduce the risk. And that's how they need to be thought of.
Well, some people are even advocating using double masks now against the the variants that are much more transmissible, particularly the UK types and the South African types. Yeah.
And again, there, I think, Adiba, it's about reducing viral load. So, if it has two barriers to go through, presumably. But again, my harm reduction approach here is if somebody finds it difficult to even wear one, rather wear one than go without a mask at all. And so, you know, my approach is always one of harm reduction, if at all possible.
Absolutely. Linda Gale, a question from Victoria McDonald from Channel 4 News UK. It's in relation to COVID and HIV vaccines. Do you think that the speed by which a vaccine was developed for COVID-19 will provide any lessons for the future of an HIV vaccine? Or is it that HIV is so much more complex than COVID-19, so developing a vaccine is always going to be more difficult? Or is it from a lack of political will?
I think the second, you know, the fact that we are dealing with a harder pathogen, a more complex pathogen, what it does is it creates these glycoproteins around its equivalent of the spike protein. So it sets up that harder sort of barrier to get over. The fantastic thing about COVID is the thing everybody thought would be very antigenic has proven to be very antigenic, and we can get at it relatively easily, namely the spike protein. The problem with HIV is that its antigenic parts are more camouflaged, and they camouflage from the human immune system as well. And if you think about it, most people get over COVID. There are people who die, but most people are cured. We don't see that with HIV. So this is the difference in the pathogens. Having said that, as somebody who is part of the global HIV vaccine enterprise, as you know, and those of us in the HIV field, we really hope that what we've seen with COVID could be somewhat translated into HIV. And that is namely, you know, many great manufacturers and minds coming together to say, how do we solve this problem together? And, you know, I would hope that maybe there'll be, and of course the resources, we're talking about billions went into the discovery of a COVID vaccine. Where about 1/10 of that is what we're seeing, if even less, in the HIV space, and even another zero off when you're talking about TB, which is our other big, you know, pandemic to solve. That more interest from people, I think, would help to expedite the discovery of an HIV vaccine. And so political will and financial will would contribute, I think, a lot more than has been the case.
Okay, thanks, Linda Gill. And along the lines of HIV and COVID, another question from Marilyn Maccioni from Associated Press. Do the vaccine results in HIV positive people suggest, what do the vaccine results in HIV positive people suggest about the risk in this population? Will they have trouble in developing immunity?
You know, I don't think so.
Data?
I don't think we have enough data, Adiba, is the quick answer. But what I would say is, although we thought that HIV, people living with HIV, particularly if they were, you know, not on antiretrovirals, very advanced, that we would lose them to COVID very quickly. We have not seen that. So the South African data, I know there's other data that's also come out from the UK now. The South African data would suggest that, you know, maybe twice the odds of going down with severe disease or death if living with HIV compared to the rest of the population. So we'd seen that diabetes and other comorbidities have much more of an impact than HIV in this case. So that heartens me that you know, a vaccine, because we're trying to elicit a specific kind of response, that would augur well. And certainly, you know, the data we've got to date is too little for us to pronounce on that in a big way. But again, if people are on antiretrovirals, if they are virally suppressed, if they are reconstituting their immune system, there is no reason not to think they shouldn't be vaccinated. If they're not on antiretrovirals, then they should be, right? The world now just about wholeheartedly, I don't think there's anywhere that it does not recommend that people should get onto antiretrovirals. The most important thing for that individual is to start their antiretrovirals. The next important thing will be to get a COVID vaccination. So that's the approach I would take. And if you are on ARVs and you are virally suppressed, you should be vaccinated if you can lay your hands on a vaccine.
Okay. Here's a question. Well, I don't know if South Africa insists on this. Certainly in Malaysia, we did not. Some countries insist on doing further tests in their respective countries, notwithstanding prior approval by the US FDA. How important are these tests, which may take a few months, versus the need to accelerate vaccination?
So my understanding is today, I haven't really heard the news whether it's happened, but we were going to be getting our first consignment of AstraZeneca vaccine called Covishield, which is coming from India. That was going to go, that's directed at our very frontline first phase vaccinees. And I understand that it is going to go to a facility where tests will be done to be sure that actually what we expect to be in the vials is in the vials. Now, I would imagine that most regulators would want to do that at least, but I don't think we need to redo the clinical trials. That seems to me, that would definitely hold things up. But I do think getting, being sure that we have got reliable products and they can be reliably rolled out is probably required by most countries in terms of their, just their regulations. And I understand that'll be happening in South Africa. What is something similar likely to happen in Malaysia, Adiba?
Well, we're about to receive the Pfizer vaccine, I think, and we will not need to undergo, clinical trials and so forth. But as was asked a lot earlier, there are some countries and that are rolling out vaccines that have not had much published results in peer-reviewed journals. I think in those situations, it is prudent. And certainly Malaysia is undertaking one of those clinical trials, that we go through the motion of undertaking phase 3 clinical trials as one needs to do, right?
Yeah, I mean, my proviso here was this was with mainstream, sort of vaccines that have published efficacy data.
Yeah. We only have 2 more minutes left, Linda Gale, and there are a few journalists who are asking about export controls. One is from Sarah Wheaton at Politico. Should US cancel export control? And earlier, Busulin from Malaysia asked if the EU should cancel export controls. Your thoughts on this?
So what I'm going to do is use the last 2 minutes to direct the wonderful journalists and media folk on this call to attend tomorrow. There are 2 terrific panels that contain both activists as well as leaders of agencies, funders, other individuals. Who will be dealing specifically with this access policy issue. And so I really recommend that people attend those and hear the discussion there. Tony mentioned that, there is a number of activists and advocates now in a number of countries coming together to get behind the people's vaccine as a concept. And to call out that maybe we need a dispensation for life-saving commodities in a setting such as we find ourselves now, so that we're not, cast your mind back to 2000 when we were scrambling again to access life-saving therapy, and we had to go through all this.
We should learn from that, yeah.
Exactly, but to do it in the heat of the moment is always tricky. Can we not get to a point where we have a clear set of dispensations for life-saving commodities should a pandemic like this occur, so that we can very clearly say these kinds of interventions, innovations, need to be treated differently to these. One recognizes, manufacturers have shareholders, they too need to survive, we get that. And we don't want to, obviously, one of the reasons we don't have a lot of people providing inputs to HIV vaccinology is this very specific reason, isn't it? So we don't want people to go away from this space, but we do need to have a different approach to when, we see wholesale life lost in one region of the world purely because of the misfortune that those individuals have to be living in that region of the world.
Thanks, Linda Gale. And one last question from Anjana Ahuja from FT. You'll have to answer this one. How often can we expect new variants to evolve? And I guess both of us can also ask a follow-up question. It was actually directed to Tony, whether each country should have a disease forecasting service like the newly announced National Center for Epidemic Forecasting. I would say Malaysia, we would love one. But if you could answer, yeah.
So Adiba, surveillance is so important.
Key, isn't
it? The reason we picked up these and they became the South African variant or the UK variant was because we were looking, right? And we were looking because we've got all this machinery for HIV. And so, hats off to the team here who picked up the variant very early on and was able to report it. But what we do know, and I think this is important to realize, this is a virus that is an RNA virus. Its machinery fails regularly and mutations occur. It only mutates if it's replicating. It's only replicating if it's transmitting. That is the bottom line. So it is in our hands how quickly these mutations will happen. If we let it have free range, if it has a free-for-all in terms of transmission, replication, and therefore mutation, we will see more variants. This virus has one mission, and that is to stay on the planet. Therefore, it is Darwinian principles. It will mutate to keep itself on the planet. And so we need to shut it down in a wholesale fashion. We now have the tools to do that. We need to get the tools out there into people's arms, use NPI in the meantime while we wait. But we should keep this opportunity as small a window as possible to ensure that we shut down transmission as quickly as possible.
And all over the globe, we need to do that, not just in the rich.
Correct.
Countries. Yeah. Mm-hmm. So on that note, we're a little past 10. There are still a lot of questions. Do we want to keep going, Linda Gale? Or
I'm also going to have to jump, Adiba. So we're hoping to talk to all the J&J participants right this moment. So I'm going to call it a day, if that's okay.
Well, thank you very much. And thank you to our friends from the media for joining us this evening for me and afternoon or morning for you. And hope you will join us for the rest of the conference. Some of your questions will be answered in those sessions. So thank you once again for joining us.
See you tomorrow. Take care. Thanks so much, Adiba.